Good morning, Dr. Phil here. Today we'll be discussing on cranial nerves 1 to 4. Introduction. Cranial nerves are bundles of sensory and/or motor fibers that emerge through foramina or fissures in the cranium and are covered by tubular sheaths derived from the cranial meninges. Textbooks describe the 12 pairs of cranial nerves by numbering them 1 to 12 from rostral to caudal. The names of the cranial nerves reflect their general distribution or function. Cranial nerve nuclei. Fibers of cranial nerves connect to cranial nerve nuclei. These nuclei are groups of neurons in which sensory or efferent fibers terminate and from which motor or efferent fibers originate. Cranial nerves 1 and 2 involve extensions of the forebrain, whereas the nuclei of other cranial nerves are located in the brainstem. Topographical origins. Cranial nerve 1 originates from telencephalon, cranial nerve 2 from diencephalon, cranial nerves 3 and 4 from the mesencephalon, cranial nerves 5, 6, 7 from the pons, and from the medulla oblongata, cranial nerve 8, 9, 10, 11, and 12. Cranial nerves 13 and 14 have been described in literature. Cranial nerve 13, also known as nerve 0 or nervus terminalis. It originates close to the olfactory bulb but is not part of it. Function. Cranial nerve 13 appears to mediate the release of luteinizing hormone. It may play a role in the regulation of reproductive behavior. It has projections to septal nuclei and the preoptic areas of the brain which is associated with sexual behavior, including the response to pheromones. Cranial nerve 14 is also known as nervus intermedius. It is located between cranial nerve 7 and 8. This nerve has usually been considered to be part of cranial nerve 7, the facial nerve. However, it has a different origin in the brain and subserves different functions. Its function includes sensory supply for taste and sensory innervation of part of the outer ear, the nose, and the mouth. Motor function includes lacrimation, salivation, and contraction of the orbicularis oris muscle. Cranial nerve 1, the olfactory nerve. The olfactory nerve emerges from the forebrain. The nerve cell bodies of this cranial nerve is located in the olfactory epithelium, also known as the olfactory organ. It exits the cranium via the foramina in the cribriform plate of the ethmoid bone. Course. Olfactory receptor neurons are both receptors and conductors. The apical surface of these neurons have olfactory cilia, which are bathed by mucus secreted by olfactory glands. Olfactory cilia are stimulated by molecules of an odoriferous gas dissolved in the mucus. Olfactory epithelium also contains free nerve endings of cranial nerve V1. Fibers arise, about 20 olfactory nerves, from the olfactory receptors on each side of the nasal mucosa and form the right or left olfactory nerve. Their axons pass across the cribriform plate to the olfactory bulb. Olfactory nerve fibers synapse with mitral cells in the olfactory bulb. Axons of these secondary neurons in the olfactory bulb form the olfactory tract to reach the olfactory cortex. Each olfactory tract divides into the lateral olfactory striae, which terminates in the piriform cortex of the anterior part of the temporal lobe, and the medial olfactory striae, which projects through the anterior commissure to reach the contralateral olfactory structures. General functional types of fibers: special sensory, general distribution, olfactory mucosa of the nose, main action of cranial nerve 1, to transmit sensation of smell from the nasal mucosa at the roof of each nasal cavity and at the superior sides of the nasal septum and superior concha. Testing of cranial nerve 1. The subject is asked to sniff and identify recognizable smells from aromatic substances such as coffee, chocolate, vanilla, vinegar, or camphor. Peppermint, ammonia, and menthol stimulates the free nerve endings of cranial nerve V1 and thus are not a good test of cranial nerve 1. Each nostril is tested separately and determined if any loss of smell is uni or bilateral. Causes of anosmia. bilateral anosmia, upper respiratory tract infection, COVID-19 infection, trauma, smoking, old age, Parkinson's disease, tumors of the ethmoid bones, congenital ciliary dysmotility syndromes, etc. Bilateral anosmia is usually caused by nasal causes rather than neurological causes. Unilateral anosmia can be caused by mucus blocking the nostril, head trauma, subfrontal meningioma, etc. The optic nerve, cranial nerve 2. The optic nerve arises from the forebrain or the diencephalon. Its nerve cell bodies are located in the retina. It exits the cranium via the optic canal. Course. The visual pathway begins with the photoreceptor cells, rods and cones in the retina. The human retina contains about 120 million rod cells and 6 to 7 million cone cells. The responses from rods and cones are transmitted by bipolar cells to ganglion cells. The central processes of ganglion cells form the fibers that are conducted by the optic nerves. Fibers arises from the retina and form the optic nerve, which courses through the optic foramen. The optic nerve begins deep to the optic disc, where the unmyelinated axons of retinal ganglion cells pierce the sclera and becomes myelinated. Optic nerves are surrounded by extensions of cranial meninges that extend all the way to the eyeball and subarachnoid space that contains CSF. Central artery and vein of the retina traverse the meningeal layers and courses anterior to the optic nerve. In the middle cranial fossa, two optic nerves form the optic chiasma by partial crossover of fibers. The optic nerve travels posteromedially in the orbit to exit through the optic canal and enters the middle cranial fossa. Fibers from the nasal half of each retina cross over in the optic chiasm and join uncrossed fibers from the temporal half of the retina to form the optic tract. This partial crossover of optic nerve fibers allows binocular vision and depth of field perception. Most fibers of the optic tract terminate in the lateral geniculate body of the thalamus. From here they splay out such that those from the upper retina pass through the parietal lobe, the others through the temporal lobe. These fibers are relayed to the visual cortices of the occipital lobes. General functional type of fibers in cranial nerve 2 is special sensory, general distribution to the retina of the eye, main action to transmit vision from the retina. Testing of the optic nerve. Visual acuity is tested by using eye charts such as Snellen charts. If the patient is unable to see the Snellen chart, test if they can count fingers, see hand movements, or see light. Examples of causes of visual loss: for the cornea, dry eyes, corneal abrasion, corneal ulcer, hepatic keratitis, corneal edema such as in acute angle closure glaucoma, and keratoconus. For the causes in the anterior chamber, iritis, hyphema, hypopyon. For the lens, cataract. For causes from the vitreous chamber, vitreous hemorrhage, vitritis. For causes in the retina, branch or central artery or vein occlusion, retinal detachment, macular degeneration, macular edema, hypertensive retinopathy. For causes of the optic nerve, optic neuritis, ischemic optic neuropathy, papilloedema. Pituitary tumor and meningioma can compress the optic chiasm, causing visual loss. Stroke or tumor can cause visual loss via damage to the optic tract or occipital cortex. Testing of visual field. First, sit opposite the patient 1 meter apart, eyes level. Ask the patient to cover their right eye while you close your left, and ask them to look into your right eye. Test each quadrant individually. Hold a red-headed pin or similar red object or a wriggling finger. Stretch your arm out and up so that the red-headed pin is just outside your field of vision at an equal distance between you and the patient. Slowly bring the red-headed pin into the center and ask the patient to say yes as soon as they can see it. Ensure they keep looking at your right eye. You should both able to see the red-headed pin at the same time. Map out any areas of visual loss if present. Test each eye in turn. Examples of visual field defects. Unilateral visual loss. Sudden causes includes trauma, acute glaucoma, retinal detachment, vitreous hemorrhage, central retinal artery or vein occlusion, migraine, transient ischemic attack, stroke, space-occupying lesion, optic neuritis, temporal arteritis, quinine, methanol, pituitary apoplexy, etc. Gradual causes of unilateral visual loss includes optic atrophy, chronic glaucoma, cataracts, macular degeneration, tobacco amblyopia, etc. Bitemporal hemianopia occurs when temporal half of each visual field is lost. Causes includes damage to the center of the optic chiasm such as by a pituitary tumor, craniopharyngioma, suprasellar meningioma, etc. Homonymous hemianopia. The right or left side of vision in both eyes is lost. If the central part of vision, the macula, is spared, the lesion is likely in the optic radiation. If there is no macular sparing, the lesion is in the optic tract. Upper quadrantanopia suggests a lesion affecting the optic radiations. Lower quadrantanopia suggests a lesion affecting the optic radiations. In a research by Jacobson DM, the localizing value of a quadrantanopia, the authors concluded that a patient with a neurologically isolated quadrantanopia is likely to have a lesion in the occipital lobe, although in the case of superior quadrantanopia, the possibility of a temporal lobe lesion cannot be excluded using clinical criteria alone. Quadrantanopias caused by lesions of the parietal lobe are usually associated with other localizing signs. Other visual field defects. Tunnel vision, which consists of constricted visual field, can be caused by glaucoma, retinal damage, etc. An enlarged blind spot can be caused by papilloedema or choroiditis. Scotoma, which is a hole in the visual field, can be caused by macular degeneration, vascular lesions, toxins, multiple sclerosis, etc. Oculomotor nerve, cranial nerve 3. The oculomotor nerve arises from the midbrain. Location of nerve cell bodies for somatic motor is located in the midbrain. For visceral motor, presynaptic is located in the midbrain, postsynaptic located in the ciliary ganglion. There are two oculomotor nuclei in the midbrain, the somatic motor nucleus of the oculomotor nerve and the visceral motor parasympathetic accessory nucleus, also known as the Edinger-Westphal nucleus of the oculomotor nerve, which is located dorsal to the rostral 2/3 of the somatic motor nucleus. Cause. Cranial nerve 3 emerges from the midbrain and pierces the dura mater lateral to the sellar diaphragm. Afterwards, it runs through the roof and lateral wall of the cavernous sinus. Cranial nerve 3 leaves the cranial cavity via the superior orbital fissure to enter the orbit. It divides into two divisions within the superior orbital fissure, the superior division, which supplies the superior rectus and levator palpebrae superioris, and the inferior division, which supplies the inferior rectus, medial rectus, and inferior oblique. The inferior division carries presynaptic parasympathetic visceral efferent fibers to synapse at the ciliary ganglion. Postsynaptic fibers from the ciliary ganglion pass to the eyeball in the short ciliary nerves to innervate the ciliary body and the sphincter pupillae. General functional types of fibers in cranial nerve 3, somatic motor and visceral motor. General distribution of cranial nerve 3 to the intraocular muscles and 4 extraocular muscles as mentioned. Main actions. Somatic motor. Motor supply to the superior rectus, which direct gaze superiorly and secondarily rotates the top of the eye towards the nose. The medial rectus, which directs gaze medially. The inferior rectus, which directs gaze inferiorly. Secondary action of the inferior rectus is the rotation of the bottom of the globe towards the nose. Motor supply to the inferior oblique, which primarily rotates the bottom of the globe towards the nose and secondarily moves gaze upwards. And the levator palpebrae superioris, which raises the superior eyelids. Visceral motor supply. The cranial nerve 3 supplies parasympathetic innervation to to the sphincter pupillae, which constricts pupils, and ciliary muscles, which accommodates the lens of the eye. Testing the third cranial nerve. Pupils. Assess the shape of the pupil. Dilated pupils can be caused by iris trauma, pharmacological causes such as atropine, LSD, psilocybin mushrooms, cocaine, amphetamine, and SSRIs. Cranial nerve 3 lesions, including raised ICP. Constricted pupils can be caused by pharmacological causes such as alcohol, opioids, antipsychotics, pilocarpine, etc. Chronic Eddy's pupil, iritis, OH, sympathetic nerve damage, pontine damage. Irregular pupils can be caused by anterior uveitis, trauma to the eye, syphilis, etc. Assess for symmetry of the pupils. Unequal pupils, also known as anisocoria, can be caused by eye drops, eye surgery, syphilis, Holmes eddy pupil, which is caused by denervation of the sphincter pupillae and ciliary muscles due to Lyme disease, syphilis, parvovirus B19 infection, HSV, and autoimmune causes. It may be a benign incidental finding. Signs of a Holmes eddy pupil includes a dilated pupil, anisocoria greater in the light, poor response to light and accommodation. Deep tendon reflexes may be reduced or absent. Argyll-Robertson pupil can cause unequal pupils. This is due to neurosyphilis, Lyme disease, HIV, zoster, diabetes mellitus, sarcoidosis, MS, paraneoplastic syndrome, or vitamin B12 deficiency. Signs of Argyll-Robertson pupil includes constricted and irregular pupils, absent light reflex, and brisk constriction to accommodation. Pupil involving cranial nerve 3 palsy. The pupil is fixed and dilated with associated ptosis, eye held down and out with restricted eye movement. Causes of cranial nerve 3 palsy includes subdural hematoma with uncal herniation, posterior communicating artery aneurysm, tumor, vasculitis, etc. Hutchinson pupil can cause unequal pupils. This is due to increased unilateral intracranial pressure. The ipsilateral affected pupil first constricts and then widely dilates. The other pupil then undergoes the same sequence. Anisocoria can be a normal variant. It can be also caused by other unilateral lesions in the brain. Ptosis refers to drooping of the upper eyelid. Causes includes cranial nerve 3 lesion. Cranial nerve 3 innervates the levator palpebrae. Unilateral complete ptosis occurs with cranial nerve 3 damage. Look for other signs of cranial nerve 3 lesion. If eye pain occurs, suspect infiltration such as due to sarcoidosis or lymphoma. If there is fever or reduced consciousness, suspect infection. Sympathetic paralysis can cause ptosis. Cervical sympathetic nerves innervate the superior tarsal muscle. Unilateral partial ptosis occurs, which can be overcome by looking up. Look for signs of Horner syndrome. Myopathy, such as dystrophia myotonica and myasthenia gravis, can cause ptosis. Ptosis can be congenital. Typically, it is partial and without other neuromuscular signs. Observe for ocular deviation. Light reflex. The direct pupil light response. Pupil constriction is caused by sphincter pupillae contraction, which is innervated by parasympathetic nerves. Shine a torch and observe the pupil reaction in the eye. When light is shined on the right eye only, light is detected by the retina and converted into action potentials, which are transmitted by the optic nerve. Action potentials from the right eye reaches both the right and left pretactal nuclei. The pretactal nuclei stimulate both sides of the Edinger-Westphal nucleus, even though the light was perceived only in the right eye. The right and left sides of the Edinger-Westphal nuclei generate action potentials through the right and left oculomotor nerves, causing both pupils to constrict. Parasympathetic preganglionic motor fibers connect the Edinger-Westphal nucleus to the ciliary ganglion, and postganglionic fibers connect the ciliary ganglion to the sphincter pupillae via short ciliary nerves. Consensual pupil response. Shine a torch into one eye and observe pupil reaction in the other eye. A quadruple innervation ensures that both pupils constrict when light is shown in either eye. Nasal retinal fibers cross at the optic chiasm and connect to the contralateral pretectal nucleus, which innervates both Edinger-Westphal nuclei. Temporal retinal fibers connect to the ipsilateral pretectal nucleus, which also innervates both Edinger-Westphal nuclei. Relative afferent pupillary defect (RAPD). To test for this, with the patient sitting opposite, shine a pen torch into one eye for 2 to 3 seconds and then quickly swing the light into the other eye. Watch out for an initial pupillary dilation. When there is a defect in the afferent pathway, such as during optic nerve damage, shining a light into the affected eye will cause both pupils to initially dilate. This is because when there is reduced afferent input from the affected eye, the consensual pupillary relaxation response from the normal eye predominates. Causes of RAPD includes optic neuropathy, such as that caused by optic neuritis, compressive lesions, etc. Gross retinal pathology, such as that caused by central retinal vein occlusion, retinal detachment, etc. Optic chiasm and tract lesions, such as that caused by infarction, demyelination, etc. Accommodation reflex occurs when looking at a near target and consists of lens accommodation, convergence, and meiosis. Pathways tested are as for light reflex. With the patient sitting opposite you, the patient first looks at a distant object, then hold up an accommodative target approximately 30 cm in front of the patient and watch for pupil constriction and convergence of gaze. Light near dissociation. There is absent or sluggish pupillary response to light, but normal accommodation reflex is present. Causes for light near dissociation includes afferent conduction defect, such as in optic neuropathy, Holmes-Eddy pupil, Agril-Robertson pupil, aberrant third nerve regeneration, myotonic dystrophy, perinote dorsal midbrain syndrome, etc. Testing the sympathetic system in cranial nerve tree. Pupil dilation is caused by dilator pupillae muscle contraction, which is under sympathetic control. 3 neurons are involved in the sympathetic innervation of the dilator pupillae: central, preganglionic, and postganglionic neuron. The central neuron. This neuron descends from the posterior hypothalamus through the ipsilateral brainstem to reach the ciliospinal center of Butch in the intermedial lateral horn of the spinal cord between C8 and T2. The preganglionic neuron ascends close to the apical pleura and terminates in the superior cervical ganglion in the neck. The postganglionic neuron ascends along the internal carotid artery and joins the ophthalmic division of the trigeminal nerve in the cavernous sinus, and then terminates in the dilator pupillae muscle via the long ciliary nerve. The dark response. To test for this, ask the patient to fixate on a distant target and measure pupil sizes with a ruler. Dim the room lights and repeat the measurements. If anisocoria is present, the larger pupil in bright conditions is likely to be the abnormal one and vice versa. Horner syndrome. This is an oculosympathetic palsy due to interruption of the cervico-thoracic sympathetic chain at the first-order neuron level, second-order neuron level, or the third-order neuron level. Causes of disruption of the first-order neuron level includes Arnold-Chiari malformation, basal meningitis such as due to syphilis, basal skull tumors, cerebral vascular accident or Wallenberg syndrome, lateral medullary syndrome, demyelinating disease such as in multiple sclerosis, lesions in the hypothalamus or medulla, intrapontine hemorrhage, neck trauma such as traumatic dislocation of cervical vertebrae, traumatic dissection of vertebral artery, high cervical spinal cord injury above T2 level, pituitary tumor, syringomyelia. Causes of second-order neuron damage includes Pancoast tumor, tumor at the apex of the lung, which is most commonly squamous cell carcinoma, birth trauma with injury to the lower brachial plexus, cervical rib, aneurysm or dissection of the aorta, lesions of the subclavian or common carotid artery, central venous catheterization, trauma or surgical injury such as in radical neck dissection, thyroidectomy, carotid angiography, radiofrequency tonsil ablation, chiropractic manipulation, and coronary artery bypass grafting. Chest tubes, lymphadenopathy, such as caused by Hodgkin disease, leukemia, tuberculosis, or mediastinal tumors, mandibular tooth abscesses, lesions of the middle ear, such as acute otitis media, and neuroblastoma. Causes of third-order neuron damage includes internal carotid artery dissection, which is associated with sudden ipsilateral face or neck pain, Rader syndrome, also known as paratrigeminal syndrome, which is oculosympathetic paresis and ipsilateral facial pain with variable involvement of the trigeminal and oculomotor nerves, carotid cavernous fistula, cluster or migraine headache, herpes zoster. Regional anesthesia may cause Horner syndrome, such as that caused by brachial plexus block, cervical plexus block, intercostal nerve block, thoracic epidural anesthesia, and extrapleural regional anesthesia. In the vast majority of cases, the symptoms disappear after discontinuation of the regional anesthesia. Signs of Horner syndrome includes the classical triad of ipsilateral partial ptosis, anhidrosis, and meiosis. Other signs include anophthalmos, ipsilateral iris heterochromia, which is different or lighter colored iris if the lesion is congenital or long-standing, normal or slight delay of pupillary dilation. There is no RAPD. Internuclear ophthalmoplegia (INO) is caused by an interruption of the medial longitudinal fasciculus (MLF) that interconnects the nuclei of cranial nerves 3 and 4 on opposite sides, which can be due to multiple sclerosis, vascular pathology, HIV, syphilis, Lyme disease, brainstem tumors, and phenothiazine toxicity. Signs for INO includes if there is a unilateral lesion, weakness in adduction of the ipsilateral eye, with nystagmus of the contralateral eye only when abducting, horizontal diplopia occurs. Incomplete or slow abduction of the ipsilateral eye during lateral gaze, convergence is preserved. For bilateral lesions, the eye may be bilaterally exotropic, vertical nystagmus may occur, impaired visual pursuit, and convergence is intact in posterior lesions but absent in anterior and mesencephalic lesions. Eye movements. Eye movements are controlled by cranial nerves 3, 4, and 6, and are also controlled by supranuclear centers that control conjugate eye movements or versions, where both eyes move in synchrony. Testing for voluntary eye movements enables detection of cranial nerve 3, 4, and 6 palsies. First, ask the patient if they have any diplopia in the primary position when looking straight at you. When sitting opposite the patient, ask them to follow a target, such as your finger, without moving their head. Examine the 9 positions of gaze and avoid extremes of gaze. Ask if the patient have double vision in each position. Watch for failure of eye movements or abnormal movements such as nystagmus. Perform a cover test in each position. Cranial nerve 3 palsy. Signs include ptosis. The affected eye is exotropic and hypotropic, down and out. Ophthalmoplegia in all directions other than laterally and inferiorly. Mydriasis is variable. Parasympathetic fibers which control pupil constriction lies near the surface of cranial nerve 3 and are supplied by surface blood vessels. These fibers are thus vulnerable to compressive lesions. If pupil dilation is present, this suggests a compressive cause. Causes of cranial nerve 3 palsy includes that caused by microvascular causes, such as associated with diabetes and hypertension, intracranial aneurysms, often posterior communicating artery is involved, trauma, tumors, demyelination, vasculitis, and congenital causes. Next, we move on to the trochlear nerve, cranial nerve 4. This is the smallest cranial nerve in terms of number of axons it contains. It arises from the midbrain. Its nerve cell bodies are located in the midbrain. The motor nucleus of cranial nerve 4 lies inferior to the cranial nerve 3 nuclei at the level of the inferior colliculus in the midbrain, and it receives input from the vestibular system and the medial longitudinal fasciculus. It exits the cranium via the superior orbital fissure. Cause: cranial nerve 4 is the only cranial nerve to exit from the dorsal surface of the midbrain. It then pierces the dura mater at the margin of the tentorium cerebelli. It passes anteriorly in the lateral wall of the cavernous sinus. It then enters into the orbit via the superior orbital fissure to supply the superior oblique. It has the longest intracranial subarachnoid course of all cranial nerves. Functional types of fibers in cranial nerve 4 is somatic motor. General distribution of cranial nerve 4 is to the superior oblique muscle. The superior oblique muscle primarily rotates the top of the globe towards the nose and secondarily depresses gaze. Overall action is directing the gaze inferiolaterally or inferiorly from the adducted position. Testing of cranial nerve 4. Refer to testing of eye movements under cranial nerve 3. Cranial nerve 4 palsy signs includes vertical diplopia, worse on down gaze, slight external rotation of the affected eye. The patient's head may be tilted to the opposite side to compensate. Hypertropia. The eye sits higher than the contralateral side. It is worse on contralateral gaze and ipsilateral head tilt. Limitation of depression in adduction. Causes of cranial nerve 4 palsy includes head trauma, microvascular disease, congenital causes, and other causes such as hemorrhage, infarction, demyelination, tumors, and infection. These are my references. Thank you.